some work that we're doing with Jeannie Brooks-Gunn, where we're looking at the impacts of housing voucher programs on outcomes. And this one of the fascinating things that was brought to my attention here was work done out of the Moving to Opportunity study, which looked at the effects of these housing vouchers on outcomes for boys and girls, teenage boys, teenage girls. And what they found was very, very encouraging at the same time as very thought-provoking. So among the girls, what they found was largely positive. So they found obesity levels had reduced in the teenage girls in the intervened group compared to the control group. Pro-criminal involvement had also decreased, and likelihood of high school graduation had increased. Altogether, good outcomes. Among the boys, though, what they found was very mixed. Obesity levels and high school graduation were a wash. Not too much in the way of change. Pro-criminal involvement actually went up. Now, the problem is that a lot of their traditional survey instruments, the instruments that were deployed here, were at a level of granularity that they couldn't tease out what was behind these changes reliably. So we know that traditional survey instrument elicitation through self-report of things like physical activity, things like sedentary behavior, factors such as diet, such as social companionship, who you're spending time around, and even where you're spending time, it turns out from some of our work, they're pretty spotty in terms of their accuracy. We know from the NHANES 3 study here in the States, the National Health and Nutrition Examination Survey, where there were actually physical measures used to complement the self-report. We know the self-report were way off base for things like physical activity. And so, when it came to sort of explaining these impacts on obesity and pro-criminal involvement, there's many hypotheses that couldn't really be pinned down with enough specificity to determine which was likely mediating these effects. The data was just not accurate enough and rich enough to really understand these things. So, there are some hypotheses that perhaps this move to the mixed income neighborhood made possible access to greater amounts of recreational space, and that led to higher moderate to vigorous physical activity, lowered BMI, and therefore lowered obesity levels. Other hypotheses might emphasize perceived safety, that now in the new neighborhood you can be out and about the neighborhood at all hours, and as a result that increased physical activity and lowered sedentary behavior. But other hypotheses emphasize the fact that in this new neighborhood there was better access to food. They left the food desert and came into an environment which had stores offering produce and fresh fruits and vegetables, not just convenience stores. It increased the healthiness of diet, which favorably affected BMI and therefore lowered obesity. Yet other hypotheses argued maybe what happened is the girls were spending more time at home. Their social networks were largely cut off from the old neighborhood. They were now in a neighborhood where they didn't know many people, and they were eating mom's home cooking rather than going out to McDonald's. Maybe they were spending time at home instead of hanging out with other folks in the neighborhood, and that lowered the risk of pro-criminal association. So there are many hypotheses about why we see these effects, many hypotheses involving different pathways. And for boys, there was the thought that perhaps they were going to the old neighborhoods, hanging out in the old neighborhoods now without the benefit of parental supervision, so they're getting into trouble by hanging with the wrong elements. They weren't having people watch out for them. A lot of theories, a lot of talk, not a lot of evidence to bring to bear. So it turns out that when we build models, and I won't go into another case of this, but when we build models, we're asking a lot about the pathways. We're asking a lot about how things work out there in the world. And sometimes we come up short in terms of the evidence, and we end up hypothesizing. And that's fine. We think it may work this way. Models can give you great benefit there. But if only we had more information, we could more quickly falsify those hypotheses. We could more quickly learn. So if we had more data, we could learn more effectively, more deeply from these models more quickly. So we've been making use of techniques that are increasingly labeled by big data. Sometimes they're called, I prefer the term data science. They have a lot to do with this world that's emerging, a world that, if it hasn't struck you yet in your professional lives, may do so within the next 5 to 10 years, where increasingly a lot of the data we receive is electronically mediated. It's collected at a much greater volume, much greater velocity in terms of the speed of receiving it, and a much greater variety of types of information that are typically collected, and often with lower burden. So we don't have to ask people very detailed questions, get them to fill out an exhaustive survey. Instead, there's a lot we can collect automatically. And I'm going to provide you one glimpse just to give an illustration of our platform. We have this platform, MyEpi, which is an Android-based, smartphone-based platform. And I want to give you a feel for the sorts of information that this produces. Not because I want to sell you on IEPI, although I think it's a great tool, and we're working with many investigators with this, but because it's indicative of the sort of opportunities within this space. So this is an app. We started our first generation system about 6 years ago, and this is our second generation system. We've had funding and support from many different avenues, and a lot of this has been motivated by the desire to build better models in these areas. So basically, there's the system, it runs on the phone, it records a bunch of data, and it sends this data over opportunistically. What I mean by that is catch as catch can. If there's a cell signal available, if there's a Wi-Fi signal data available, we'll send over data in an encrypted fashion, encrypted so nobody can make sense of it. Even I couldn't make sense of it. And it's sent over to the server, and then we process it with a variety of tools. And these tools include things like AnyLogic, this tool we've been dealing with, to help us simulate outcomes. It links up with these data, but often it passes through some statistical analysis before that, some inference, etc. So we have this data backhaul. It's secure and it's catch as catch can. So people will sometimes be carrying these phones. They'll go off the cell phone network. They'll be out at the farm or out at the reserve, our equivalent of reservations, and they'll be out of cell phone coverage for some time, and then they'll come back in, and the data will all get uploaded. And they don't have to be aware of any of this. They've gone through a consent process, and they've been asked about the level of consent, often in a tiered system, is involved for some of our studies. But a key emphasis here is adaptivity to sort of allow you to collect data with no reprogramming. You can ask it, collect this sort, that sort, collect it more frequently, collect these sort of surveys on the system without any change in programming. And you can even do it while it's live out there in the field. So a lot of the motivation for this was to collect information on these key factors that are hard to collect typically, but can play a big role in our theories about how things work in our world and by extension in our models. Things like location, physical activity, spatial proximity of people to resources, social context, and communication. It turns out that, not surprisingly, these are key points of pain, and these are some key areas that we focused our system. And without going into great detail, we leverage a lot of the tools on the device to make this possible. These devices, these cell phones, these smartphones, incredibly powerful tools that add a lot to our day-to-day work. What people don't often realize is just how chock-a-block full they are of sensors. They're huge sensor platforms, and we can use these types of sensor platforms with little or no cost to their original function and just use them to collect health information. So we can collect geographic movement, people's movement between neighborhoods of a city. We can do localization indoors as well as outdoors to figure out where people are in a hospital to study movement and mobility within a facility, or we can do it outdoors using GPS. We can look at people's contact patterns and how they evolve over time, say week 1, week 2, and we're actually getting this information every 5 minutes or so typically. So we can look at sort of micro contact patterns. And we actually found through simulation that sometimes it really matters for certain types of research questions, certain types of situations, those micro patterns really matter. We can look at things like the contact duration between different people or between potentially mom and baby or children and their parents. We can look at socialization patterns within the family. Of those girls who've been moved to a new neighborhood, what fraction of the time are they spending at home versus outside before and after the move, for example? Now, this system is designed to be highly customizable. So typically, we modify sort of the look and feel of it for a given study. So we add custom buttons and custom information displays. We can set the sampling regimen to sample more or less frequently, and questionnaires. So this system is designed, in addition to picking up sense data, things like accelerometry, things like the data on how far you are from other survey participants, where your location is. In addition to that sort of data, and what the orientation of the phone is, in addition to that, we also can get crowdsourcing information. So, for example, we have buttons that allow the respondent to report subclinical symptomology. I'm coughing, I'm wheezing, say, for asthma, or I just had a near fall. And all of that is cross-linked. All of that is cross-linked with where you are, what the weather is, of course, because you could figure that out from where you are and what time it is. It's all cross-linked in there with the sense data. So a lot of our studies have things like this. This is for some work we're doing with Harvard School of Public Health, Dana-Farber, and American Legacy Foundation. People actually volunteering pictures of tobacco advertising in their communities, for example, so that we know what exposures people come into contact with. So this is an example of a questionnaire that might pop up during the day in more of an ecological momentary assessment way. You know, how much are you craving a cigarette right now? But we can ask these questions, importantly, trigger them based on context. When you first get up in the morning, when you're near a group of people. Another study for flu sequestration, a study of the impact of flu sequestration that was done for an RCT for the US CDC. We were looking at triggering surveys when people were in a crowded location as detected by the device. In other cases, we've brought up these surveys if they're near a particular type of resource, like a fast food restaurant or what have you. We can bring up surveys that are very particular, that ask in time proximal to the point of interest, rather than requiring self-report months later. And these sorts of questions can be used to elicit things that help explain the data we collect automatically. You could think of, in a way, the system as kind of lending a voice to the participants. It's a little bit, has anyone here heard of Photovoice? Yeah, okay. Photovoice is a wonderful system, but a lot of the times, at least the traditional uses I've seen, people contribute Photovoice, but they contribute pictures, but then they have to go through a time where they situate where that photo was taken, why it was significant. We can capture all that directly on the device. We can automatically measure where they are, and we can ask them why it's significant at the time of the photo taking. And, you know, this is very, very helpful for understanding falls and injuries or tobacco advertising, safety issues, etc. So we can trigger these surveys on fixed schedules, plus on arrival, sort of at random times during the day, based on when they go to that community grocery store, or based when they're in a park or what have you. And it has a variety of types of information. You can link this sort of information with a growing number of other types of information. So we've linked it up with weight scales, for example, with things like EEGs for brainwaves to capture aspects of mental functioning. And these sorts of systems can be quite commonly found to be in a way that's compatible with our system. So one of the most valuable things here is to be able to map things out geographically, so we can look at activity level over geography, where social contacts take place, and we can cross-link it with external data sets like weather reports, GIS databases, environmental sensing systems, etc. So, you know, some of the work we've done in social determinants of health have linked this to resources, and actually looking, given the activities, given people's actually the spaces that they're using, where they're actually traveling day in, day out. What resources does it bring them near? Not just their home, not just what they put down as their mailing address, but actually where they're going. So these sorts of systems provide a great deal of insight that's longitudinal in nature. It follows an individual over time in the context often of many exposures to concerns of interest. It's making physical measurements for many things, and it can be cross-linked with these self-reports, these comments to the device. The temporal resolution here is such that, sensing things every few minutes, being able to sample, issue surveys many times an hour, you can lower greatly the amounts of recall bias, for example, that someone suffers. Their ability to recall 30 days later what they ate, for example. Often from the multiple types of data and survey responses, you can get a better sense than from any one piece of data. Let's see. I think a key value add here is this issue of learning from interventions. When we have an intervention in place, we will often see outcomes that are fairly coarse-grained in nature. We'll be looking at outcome measures. Maybe it's occurrences of repeat case visits that are required. Maybe it's continued mental health issues. Maybe it's issues having to do with prevalence of smoking. These are fairly coarse-grained things. What we often are really interested in is the pathways that give rise to them. And models are part of that dialogue, because models help you reason about the pathways. Could it be because of this? Could it be because of that we're seeing this outcome? But if we can tease out during an intervention or following it what went right and what went wrong, it helps us learn from that intervention more quickly, particularly when combined with a model. Because with a model, we can ask, well, what if we change the intervention or this way or that way? How might we see different outcomes? When we have this data collection, we can, for example, take a look at the outcomes from a given intervention before, say, and after an intervention, or control groups and intervention groups. And we can examine which pathways are the major driver for outcomes, or what pathways are working across purposes to cancel out the gains that we expected. Cases where effects are being felt in pathways, but not yet, for example, in the outcome due to delays. So let's go back to this example of moving to a mixed neighborhood. If we had a situation like that, and we could even have a sentinel group of these participants with a system like this sort of electronic system, we could, understand to the degree to which obesity levels might be changing more due to changes in sedentary behavior rather than changes in physical activity. Or for the boys, maybe their increases in physical activity were canceled out because they were engaged in greater amounts of sedentary behavior. We have a greater chance of being able to tease out these different interventions because so many of them involve location or involve things that can be measured through accelerometry, things that are measured through the presence of a social network of individuals that we can actually tease out with automatically measured data. So, here we will be have the option of using this sort of sensor device and with the self-reports and the crowdsourcing, reporting things proactively to tease out some of these pathways in ways that will help our model more quickly learn, help our model make sense of that evidence more quickly and then integrate an understanding of what interventions might be more effective. A model will typically have multiple pathways as well, and if we could pin down which pathways are more active, it lets us use that model more effectively for asking, how can we improve this intervention? How can we do it better next time, et cetera? So potentially, how can we even, in a participatory context, improve it as it's playing out over time? So these sorts of devices form a sort of key link to modeling. How do these work together with simulation models? Well, these simulation models, as we talked about, try to capture these causal relationships, these pathways that that we're trying to understand better using the data from these devices. And there's a natural synergy here. This data can help ground the models, provide grounding in observations, and it can help us estimate model parameters, these assumptions, these values that need to go into the model. For example, values associated with self-regulation, and also to calibrate the model. So to see to what degree the model can reproduce the patterns as a whole that come out of the system, to what degree those emergent patterns can be matched by the model. Meanwhile, these dynamic models help make sense of the data. Without models to make sense of them of some sort, this data that comes out of these devices is columns of numbers that is full of sound and fury, and it signifies nothing. So, so here we are using models to make sense of the data and using the data to ground the models. I would particularly, in the context of infant and child mental health, I'd like to particularly emphasize the potential for using physiologically sensed data. Smartphones are a natural way to sort of help us facilitate the collection of the data because they're so ubiquitous. They're carried by such a large fraction. I think I was eating breakfast this morning around 6:15, and there was a show on, and it said something like, if it was to believe, 75% of teenagers in the States now have smartphones. And what that provides, most importantly, is sort of a conduit for data collection that can be used with appropriate consent and ethical permissions that can be used by the investigators. But increasingly, there's a lot of interest, I know Connie's interested in this, in the physiological sense side. And some of that you get for free in the sense that you get accelerometry with the smartphone, and increasingly you're getting some aspects of temperature and so on. But for other types of sensors, things like galvanic skin response, things like respiration rate or heart rate, et cetera, increasingly you're looking to other devices. And I don't know how much you follow these things, but there's a real upsurge right now of discussion involving wearable technologies. And, you know, there was a time where it was like geek's paradise, and the only folks wearing them were you know, my fellow nerds. But the fact is that increasingly people are seeing value, for better or for worse, in actually wearing watches, necklaces. People have even tried things like, you know, wearable clothing technologies. But these are things that can sense aspects of physiological state that would have been just a few years ago very difficult. So I'm pleased to have colleagues who work in the smart watch area and that can measure heart rate, for example, as part of the watches in an unintrusive way. There's other devices that seek to measure things from blood glucose to blood oxygen levels through the skin. We are dealing now with a situation where, in short, a lot of data collection can become possible in a less intrusive way in terms of bother to the participant. All of this involves upfront, you know, concerns of dialogue with ethics boards. So before we started this work, you know, maybe about 7 years ago, 6.5 years ago, we went before our ethics board and said, look, we know we can do this technically. What are the proper boundaries? And we had a good, long dialogue. We talked with them in detail about what was acceptable, what was not. We excised certain things that would have been too intrusive. And we go through a quite rigorous consent process for things that, from the standpoint of the behavioral ethics board and biomedical ethics boards, are fairly minor risks associated with them. In any case, we find that physiological sensors, varying everything from EEG to the heart rate to respiration and galvanic skin response, these things can add a lot of power, and they can be, the signals from them often can't be directly sent home because there's not enough power, but they can send it to your smartphone, and your smartphone can send them back to the researcher. And cross-linked with all the other information, it's a very powerful combination. So in the infant and child mental health area, there's a lot that can be gained about these micro details of interactions, particularly in the first months and years of life, where, we know quite a bit from the literature, but there's still some gaps as to how things kind of function and the variety of experiences in those areas, particularly across cultural bases and experiences in terms of outcomes of interventions. So increasingly, it's not a matter, I think it was earlier, there was a question asked on the data side. I think Connie, yes, you had asked this question. What limits are there, what we can put into the models? And I said, well, there's limits in terms of wanting to keep it manageable and to learn from it in an effective way, and by adding things in step by step, that's part of it. But the other thing I would have said several years ago was that often our models outstrip our knowledge, our theory even sometimes. They outstrip what we know about the world, and that provides a kind of lower bound in the detail. But increasingly, because of what's called the data science revolution or big data revolution, increasingly we're dealing with areas where we can build the models to articulate the theory. We have to do so in a staged way, but we can mesh them with the data that actually informs them, so they're not merely speculative. They're not merely, hopeful in terms of their sort of theory about what's going on, waiting for the studies to be done to correct them. They're actually, they can actually be part of our learning process with a quicker learning loop because the data can start to come in. So in this area, the advent of these big data systems is really somewhat transformative. One of the folks in the States who I really admire on the modeling front, Scott Page of Michigan, the director for the Center for Complex Systems at Michigan, spoke at a conference I organized last week. And he said also, the world is totally different than when he started modeling. The world increasingly does have the data to inform these models, and data that makes these models all the more urgent to build. There are some challenges to these sort of models, or to these sort of data collection exercises. Some of them are information challenges, some of them are participant management, some of them are data science challenges, making sense of the information. A central element I will emphasize is the human factors. And I would particularly emphasize these in the context of vulnerable communities, which we work with a lot. I'm very privileged to be working with folks in everything from work with our community-owned grocery store in our core neighborhoods of our city, to work with in the area of gestational diabetes with predominantly lower-income women, to work with 3 low-income communities in Massachusetts with Dana-Farber and Harvard School of Public Health. And one thing we really do see is the importance of trust. We see within lower-income communities and within vulnerable groups more of a desire for snoozing the phone. So on our phone, this is an important principle, and based on discussions with our ethics board early on, we have a feature to disable data collection on demand. So we want to be able to, and this is partly desire out of dignity, to give dignity to the participants, but it's also a desire that's a very practical one to distinguish cases where the phone just happens to run out of power or happens to be shut off by accident from cases where they're shut off or not carried because of concerns for privacy. We want to be able to distinguish those things. Cases where people want more privacy from cases where, they just didn't get chances to keep their phone on. So we provided a snooze button that allows them to snooze it in every study. So they can press the snooze button, and it's going to stop all the sense data collection for however long they want, and they can specify. And you know what the surprising thing is? The surprising thing is people don't use it much.
Once you give them permission to bow out,
yeah.
They go, oh, I think
that's I think a lot of it. That's right. And so, for most of our studies, we've seen very, very little use. The one exception is with our lower income participants who in 1 or 2 cases, and I'm talking 1 or 2 out of many, many participants, they've chosen to snooze it somewhat more. And we're interested in understanding why that is. It
I jumped the gun on that because I thought you were saying within those low-income
Yeah.
households, they did not.
By and large, they don't. By and large, there's very little use, but a few individuals, quite a bit. When I say quite a bit, with all but one case, we're talking less than 10% of the time. So it's still a large volume of data. But there is one person who, remarkably, it's not quite an Olympic achievement, but it's pretty impressive. They managed to snooze the phone 70% of the time. There's some indication from some of our work that there may be power issues with the social networks. So issues having to do with, for example, concerns of privacy on the part of their spouse or others in their social network that required them to sort of turn it off at that time. Yes.
Do they have a 2-year-old?
That's a good idea. A very good point. We didn't think to ask that. Maybe we should. They might have liked that snooze button. It was one of the most accessible buttons on the app. This issue of human factors is a very important one. One thing I will say is that we're increasingly looking at models where we don't simply collect the data from people. You're not merely people out there, guinea pigs that we're collecting data from. Instead, we feed it back to them. We provide them access to the information that's collected so that they can make use of it. And sometimes it sounds skeptical, but there's this view among some researchers that this provides a more perfect mirror. It helps provide them with some understanding of their own patterns, some understanding of their needs in a way that steps back from the welter of details about their life and lets them put their patterns into context, particularly if you can compare it against aggregated data from their peer groups, for example. So, in this case, we have quite an emphasis on this idea of providing data back to individuals, either in an aggregated form or more detailed form, and providing it to communities in an aggregated form. We've had a lot of interest from rural communities, particularly in the States, with some partners, where these communities are interested in partnering, partly to understand how their investments in amenities to enhance physical activity locally, to what degree they're shaping behavior, to what degree people are actually using the walking trails more. Where is the effort falling short? Are they stopping using the walking trails because it's slippery and bad weather, or is it because it's too steep, or is it an issue having to do with lack of railings? Getting some sense as to sort of why they see those patterns and how much they're able to nudge behavior as a community to enhance physical activity was one of their real interests in partnering with use of IEPI. So to the degree that we can provide communities with a sense that they're to gain and that a person's own data will benefit their community, there may be further incentives in place to encourage data collection. So, reflective practice, the chance to improve the quality of practice based on data collected, and the opportunity for a given family's context, I think a caregiver and baby interaction, for the quality of that interaction to be improved for this and future children through appropriate tailored guidance to them based on what's being sensed. It's not a crazy question that perhaps that would be a real incentive. Rather than just being willing participants, willing subjects in a study, it may be that basically this would allow for more thorough advice giving, and it could actually benefit them and their children. So,
a neutral therapist, co-regulating therapist.
That's right. And there'd be a lot of challenges for operationalizing that and making that most effective for them. But I think it's possible. I think it really could be done. And I think you couple it with the model side, which, where do models fit in this? Well, if you could feed these data into the models help you understand the distal implications of this. Okay, so you've seen this. what does it mean if this continues in terms of these downstream indicators, for example? Where might this be going? If we've improved things, how might that yield to improve outcomes? The models can help you take that data and ask what ifs with it, take that data and say, so what's with it, in terms of where it might go. So, we're dealing here with a newer world in terms of the computational techniques, and this extends to the sort of data collection and also extends to the models. And there's a virtuous interaction, a virtuous cycle between them. They're synergistic in my view. Right. So I think I'll just conclude this particular talk by saying sensors are increasingly ubiquitous. Commodity sensor-bearing devices can serve dual uses as sensors, ecological momentary assessment tools, and crowdsourcing platforms. This crowdsourcing being like, I want to contribute that picture of this safety concern, of this stressor, or of this issue having to do with adverse physical environment. It allows people to report subclinical symptomology that clinicians would never know about, right? The signals that all go around us every day, GPS, Wi-Fi, Bluetooth, they can really help give a sense of our context, where we are right now, with whom we're co-located. And coupled with models, this sort of sensor data can offer significant and complementary health insights. Cross-link sensor-based data and EMA data, as well as other components of big data, do offer this opportunity to sharpen and not replace traditional methods and models. A key use of this data, for which models also come together, is to learn more quickly from from interventions, whether successful or not, both successful and unsuccessful interventions. So those are my comments on sort of the big data side or the data science side. That's not the focus of the day, but it does add texture, in a sense, to a certain degree of opportunity and urgency to a lot of what we're talking about with models. And certainly within the professional lifetimes of those in the room, I think this will become an increasingly big player at the table. Okay, I know I cut off a break before, and I have some work on the social network analysis side. Let's see. We are going to, should we do a 10-minute break? Okay. 10-minute break, and then I'll give a whirlwind discussion of some aspects of social network analysis. Yeah.
So in the model you're doing with the represent, and there's probably lots of answers to this question, but in that diagram,
yeah,
you have almost this idea of their ID and their DD, right? And you have their moving to existing neighborhood, and you get this doctor, right? And you're able,
right.
You have it very scarring as a model, DD levels, program,
right. Yeah.
Do this. Do they come to you with each end, and
yes.
Still in the middle?
Exactly. That was a lot of it. And I mean, there were discussions that helped us understand what lies in the middle. But the problem is that they had rough indicators, associated with the two ends. So they knew, the randomized groups and who was control, who was intervention, and they had these sort of broad outcome indicators. But they were really interested in this issue, particularly of what was going on in the middle with things like physical activity and use of space, et cetera. Yeah, I mean, we're dealing here with whole pathways in between them, and that's right. And really, part of the reason I emphasize this is because models help us articulate those pathways, and by articulating them, we can then get a sense of to what degree, certain types of data, maybe data that we aren't collecting now, but data very specifically involved in time spent at home, to what degree that might be a key variable to measure, right? We have maybe competing hypotheses. Maybe it's this way. No, maybe it's that way. All those are consistent with the data right now. But we could distinguish between those two by looking at this one variable. and it allows us to kind of focus our data collection efforts in a way that might be helpful there. Is that helpful? Yeah. Okay, very good.
Do you see any risk with the census data other than the concern about privacy and
oh yeah. Well, I think, I mean, I have fairly strong feelings about the matter, but a lot of them may not be addressing your concerns. Yeah, I mean, I do see real risks, and one of the things I'm most concerned about, and forgive me if I sound like a socialist Canadian or something, but I'm very, very deeply concerned about the fact that we go through and we bend over backwards for consent, and you know, it's all a very good process, and I'm very proud of it. And you know, often it's tiered consent where they can elect how their data is used. And frankly speaking, there's all these companies making use of this data in the most commercially crass sort of ways for free without asking any consent and collecting it en masse from devices. And I find it shocking that, you know, there's not more regulation being talked about at that level. And I do think that the sort of data that we're collecting is small potatoes compared to what, you know, many companies are collecting on a regular basis. And you know, they are just as much as we are seeking to bend the curve and change behavior, but their interests of bending the curve and changing behavior are not focused on individual well-being. It's focused on the almighty dollar. Yeah. So I have real concerns about that. I don't see the IEPI type interventions, you know, that sort of technology as really worsening that trend. In fact, I think at least it means that the cell phones will be, the data from them will be offering some benefit, but I do think it's a real concern, and I think on the regulatory side, Europe is far ahead of North America in this regard. But even they, I think, have a long ways to go in terms of some of the concerns. So I think those are some concerns. I think there's some additional concerns. For example, increasingly you know, when we started this work, we were entirely giving phones out to people. Increasingly, we're seeking to you know, use this app on people's existing phones, so it's minimally disruptive. But you want to be sure that, particularly for vulnerable communities, for lower income individuals, that they have plenty of opportunities to participate in studies. You don't want it to be contingent upon people who have only the latest smartphone models and so on, and that are up on, you know, and that are hip on sort of smartphone use. So I think it's really important that there be attempts to make sure that it's inclusive techniques. So we have done a lot of work with low-income populations, buying them cell phone plans and so on. Another issue, though, that comes in a big way here that I don't have an answer to, but you folks would be great folks to consult on, is when it comes to children. You know, people have noted that giving a smartphone is an intervention in a big way, and you have to be very cautious about that. And, you know, we have many ways we can deal with that. We can disable use of other apps from the phone, so we could have them, you know, carry it separately so they can't be surfing the web or downloading who knows what app. But I think some issues need to be worked out there in terms of ethics in kids that you know need to be elucidated, I think. But at this point we haven't been doing too much work with those below 18. Yeah, we've done a fair bit in Massachusetts. I think 15 and over. But yeah. Okay. Any other questions?
About how the new cars that are coming out are going to send even more information about us on our phone.
Yeah.